So let's move on to our next speaker here. Matthew Cook, or Matt Cook, is a managing consultant for Health IT Solutions at Guidehouse. And as a member of the Health IT Solutions team, he partners with clients to transform operations and care delivery by improving their technology and data. He is passionate about making technology an asset for both clinicians and patients while addressing inefficiencies in our healthcare system. Prior to joining Guidehouse, he worked throughout the healthcare field, specializing in electronic medical records, project management, and relationship management. Matt graduated from Virginia Tech in 2012 with a bachelor's degree in biology, and he currently serves on the Virginia Tech Alumni Association board, where he chairs the engagement committee. Please welcome me, help me welcome Matt to the stage.
Good morning, everybody. I know I am the last thing between lunch, so I will do my best to stay under 2 hours. Well, it's great to be here. As an alum, I graduated in 2012. I just think it's fantastic that Virginia Tech has this program. It's so valuable and going to give you students the skills you're going to need to be successful when you get into whatever industry and role you end up going into. They're going to be fortunate to have you with this experience that you're getting. So I'm going to talk to you all about healthcare. That's the industry I serve. Like Jay said, I work at Guidehouse, which is a firm of 17,000 employees. We service energy, financial services, defense, and healthcare. So I work in health, as I said. We also have advisory, managed services, and digital within those offerings. So I'm in the advisory arm for Guidehouse Health. So I'm going to give you a high level of the healthcare in our country initially to give you some context. Then we're going to dive into a use case of something that hospitals and health systems are solving for, and then talk about how current state analytics, AI, and technology is playing a role in that, and then look at what future state and things we're going to get excited about looking into the future. So like I said, high-level overview. When you compare America to other wealthy, developed countries, we spend way more per capita on our healthcare expenses, almost twice the average of our other peer countries, which is not a place you want to be economically. You might think, well, we're the biggest economy in the world. We have the biggest military in the world. We spend the most on that. Why is that a problem? Well, this slide is the problem, because although we spend a vast amount more than other countries, you can see the blue dot on the bottom there is the US. So when it comes to performance and outcomes, we are either at the bottom or lagging in many indicators, unfortunately. So high level, tons of opportunity. So that's the silver lining here when it comes to healthcare. There's a lot of inefficiencies, obviously. And another thing the data doesn't point out here is that where you live, your zip code, your gender, your race, unfortunately also plays a disproportionate role into these outcomes that we see as well. So that's another thing I'm very passionate about, and another opportunity for technology to address. So with the COVID pandemic, I know we're happily beyond the worst of that, but that really shone a light on healthcare and some of the biggest opportunities that the industry has. So, and a couple other big pressures you want to consider here. You've got the cost factor. You also have staff shortages. Currently, we don't have enough workers, physicians, nurses, staff to service what our aging population is forecasted to look like. So that's a concern. How do we continue to retain, recruit, and support our healthcare providers? You have financial pressures that the COVID pandemic brought. Things got more expensive, staff got more expensive, you had supply shortages. Some of these healthcare is prepared for, others not. But as a result, healthcare as a whole, specifically the healthcare like hospitals and health systems, that's who I work with and I'm focused on in this presentation. The margins went into the red. You're spending more than you should be, not bringing in enough revenue. So health systems are having to address these pressures. You can make small gains here and there, but really to truly address what the future looks like for healthcare and all of these challenges that are facing systems, they need to look at changing the operating model. So that's what I'm really going to talk about today, is one specific program and opportunity health systems are heavily investing in now to disrupt what the historic operating model looks like of a health system and how technology can play a role in that. And that's in throughput. Patient throughput is how a patient progresses from the time you enter the emergency department, the OR, however you come in. On the left-hand side, the center is intentionally busy because it's demonstrating all of the players involved. So you've got physicians, nurses, people that clean the room, lab, radiology, transport, all these players involved. Everyone's got a very full schedule every day. You've got competing pressures. And by the way, none of these people are a desk jockey like me. They are constantly on the move between rooms and meetings and huddles to talk about planning for the day and what this is going to look like. So when you think about the fact that there's all these players involved in providing care in the hospital, they are all on the same big team, but when you break it down, there's individual departments and team structures, and the fact that everyone's on the move and that technology is, on the whole, hit or miss when it comes to how healthcare stacks up to other industries. It's not hard to envision that there are inefficiencies all over the place and opportunities to improve real-time situational awareness. Ultimately, getting to that is the goal because you want to ensure that you're giving timely, high-quality care to patients. You want to make sure that you're not spending patients aren't spending more time than is necessary waiting for a treatment or waiting to go home. And from the hospital's perspective, they are incentivized to do this because in a fee-for-structure model, which most hospitals, that's how they operate, you're losing money by having patients in the hospitals longer than they need to be. You don't get paid past a certain amount because the insurers say, no, they should have been out at 2 days. Why are they here at 4 days? And so there is the revenue incentive as well, beyond the quality care that we all want to receive, whether it's you, your family, your parents, your kids. Healthcare is a very personal experience, and so you got to keep that at the center of any of these conversations. On the right-hand side of this graph, or image, is where patients get placed when they leave the facility. So you can go home, rehab center, et cetera. So it's just intended to give you all an overview of the complexity, the number of players involved, and kind of start turning the wheels of where technology can play a role to improve this. So recognizing that everything I just said, the blue circles here are where we're starting to see, some health systems have done this years ago, a lot of people are doing this now, where they are implementing a co-located, centralized command center that really becomes their platform for operations. Was it Carillion for 4 or 5 years, just up the road? They were actually on the leading edge of this. And so around 2010, they implemented one of the first healthcare operations centers, which I was seeing Megan's presentation earlier, doesn't look that different from Norfolk Southern. Also doesn't look that different from NASA. It's the same concept of you have a highly complex mission at hand, there's a lot of players. How do you maximize that situational awareness, leverage technology in the most appropriate way to make sure you're giving notifications through the best channels possible, minimizing time in front of a computer, and ultimately, again, delivering that quality, timely care that everyone is seeking. So going back to this model here, with the command center, the goal from the outset is co-location of the services that get a patient through this journey that we're looking at. So it starts with having nurses and transport staff manage all the patients coming in. So they're looking at, we've got a helicopter flying in from Charlottesville. We've got emergency department, Roanoke City on the way, 10 miles out. You've got this many people in your emergency department. We've got these many surgeries scheduled for the day. And they are real-time managing how your capacity currently meets that need, or if it doesn't meet the need, figuring out how you can. So there's a lot that goes into this from a process and operational perspective, obviously, and also from a technology side. From a technology perspective, so a lot of my career is focused on the electronic health record, which is one of the core elements of the technology that a hospital utilizes. Epic in the center is the largest player in this space. This is like a 10-year-old image too, frankly. So just to give you some context, this is just one hospital's integration map, if you will. It's not true integration, but just demonstrating which systems feed each other and the connectedness between them. So something else you have to think about with healthcare is that you've got the VA and military, they've obviously huge providers to a large amount of Americans, but when it comes to private healthcare, every hospital or health system, which is a conglomeration of X number of hospitals ranging from 5 to 150, they all have their own technology. They can decide what EHR they want to use when they implement it. It could have been 15 years ago. It could have been 15 days ago. There's tons of technology in this space. So it's not like you walk into a hospital and health system and have this just standard across the board. The players highly vary, as does the data itself. The collection of data, everyone is generally collecting the same thing. You walk into a doctor's office or the hospital, they're going to collect the same set of vitals and do the same things essentially. But where they store it, how it gets collected, and if it gets sent off to any repository or registry is going to fluctuate depending on if is it required for regulation? Is it a required quality metric? Yes. Is it required to get paid? Yes. Then it's going to be standard because those parties require it. But a lot of the information is not. So you have providers and systems that create their own forms and templates that work for them, but there's not this just national standard that exists yet. The ONC has come out just recently, last year or so, with a framework called TEFCA, the Trusted Exchange Framework, which is going to vastly improve how healthcare information is exchanged at a national level. And it's going to set standards for if you want to be one of these organizations, this is how you have to map all the information and data to ensure that the goal of getting our information where it needs to be is achieved. We all know how frustrating it is to go from one system to another or a different practice and get asked the same questions over and over again, and your physician there not to see the information from your visit a month ago. It's not ideal. So there's still a long way to go, but recognizing when you come into, again, I'm talking about this command center concept here, every client is going to be different. Every project, every situation is going to have a different flavor of technology. Generally, when it comes to command centers, their big, heavy systems are going to be their EHR, which is all the clinical documentation wraps into that. Also, operational documentation can wrap into it. Sometimes they might have a logistics platform. Sometimes they don't. Sometimes they'll use their EHR for that. And then other times they might have a niche product for like dashboards and analytics. So you obviously have to understand, in my role, I'm focused on the technology, but technology is just one of the many pieces that makes this work. Implementing something like this is incredibly disruptive in a good way, but it involves the entire hospital, frankly. So you have to get buy-in, which requires a really strong communication and governance. I know you hear these themes recurring, and there's a reason they keep coming up in different presentations, because you just simply cannot avoid having to lay that foundation of people leading the project that represent all of your stakeholders. And specifically for this, kind of changes the mindset of hospital operations, because if I was in ICU in the past, my charge nurse might have been the one that decided where that patient went next. And I might have the historical knowledge of knowing that Dr. Jones, she likes to have, she operates on Mondays and Tuesdays, so her patients are going to go in these beds. When you centralize that, you either have to pull that knowledge and literally pull that person, or develop a process and knowledge management system that accounts for that. Enable the technology to ensure that even though you are centralizing all of this, you're not losing the quality and are able to maintain and improve on the operations that exist today without it. So it's incredibly important to make sure that you've got the right stakeholders involved. The next thing we really focus on is the data itself. So what are you using today is, obviously you want to understand baseline, get a framework for how they're measuring performance today. Are they doing it in a way that's consistent across the organization? Is it consistent across hospitals? A lot of systems have grown by acquisition, which means, yeah, they have the same name and title, but when they went through that, did they really integrate, or are they just like a holding company and everyone has their own rules of the road that they follow when it comes to this? So getting to a common language of how you define your performance, where you go to locate that information, and are your metrics specific enough to actually tell you something, is very important. And an example on that front is, I could say, how long does it take a patient from the emergency department once they enter the building to get into an inpatient bed? A couple hours, a day, however long it is. You could measure that, people do, but if you think about how many people play a role in that time, if it's longer than you want it to be, where do you go? How do you pinpoint the issue? Instead, you need to break it down much further to, okay, what is the physician's responsibility? So you've come in, how long did it take to get triaged? How long did it take that doctor to decide, yes, we're gonna admit you? Once they decided that, how long did it take them to put the order in the computer that can actually be acted upon for the command center to then find a bed for the patient? So you've got to break it down to a level that makes sense. You don't have to make things overly complex, but you have to get data to a point that it tells you, either put together it tells a story, or is specific enough that you can get tangible insights from it. The other thing I touched on briefly, obviously, so this is a rendering of a command center, an actual command center. The application of analytics and technology is very important. Like I mentioned, there's many people that play a role. Some play a huge role. Some play what is a smaller amount of time, but equally important role sometimes in this whole engine of hospital operations. So you have to make sure you have a really solid understanding of what is it people do today. And that's where your time, literally, go on the units, talk to the people. There's no substitute for that. I'm a firm believer that you can have all the data in the world, but you can't mistake the human element of this. And there are things you observe when you are on site on the unit that you will miss if you're just having a conversation, interviewing someone. Despite your best efforts, there is value in getting there and speaking with their leaders, speaking with people that do this on a day-to-day basis. The other things we'll do in the assessment phase is try to understand what data can inform the design process. I feel like a lot of times it's really easy to think about data and like, what are we going to get as a result of this? What are our outputs going to be? What are the metrics? How do we measure success? Yes, all important, valid, but at the same time, what data exists out there today that can help us design better? And what I mean by that in this context of how we apply that is what workflow analysis can be done or has been done to provide tangible information on where our opportunities are. You might think you know something to the idea of like behavior versus attitude earlier, but is that true? Let's validate that if possible. And the ways you can do that is you partner with the IT department that exists today or the analytics team that exists. Understand what you can get from what's in place already, and use that data to inform your work group who's designing the ultimate end product. Operational impact, like I mentioned, of doing this obviously has to be considered. So as I mentioned, the roles vary. You've got a transporter who's using a mobile phone to get their jobs assigned to them. They rarely might touch the computer, log in, log out at the end of the day. But in an organization that has a command center live, they're likely going to just rock with a mobile phone. And that's going to be how they get their assignments and go about their processes. Whereas, physician's going to be at a desktop, most likely, writing in those orders that drive the workflow and kick this all off. So just two examples of roles where how they might interact with the technology, how they need to receive notifications, what should be automated, what should be ad hoc. These are all questions you have to ask yourself as you're coming up with your design of what this is going to look like. Current state, once you are live, what that gets you is a visibility that hospitals have not previously had into what their operations looks like. So you can, like I mentioned, there's all these players who have done healthcare very well for a long time without command centers. So if you're wondering, well, why is this necessary? Yes, we've been doing it, but like I said before, it's easy. Everyone has their own responsibilities. So if you're a nurse, I work on this unit and I'm focused on these things. If I'm a physician, I round on these units. These are my patients. I focus on these things. Having a center like this gives you that enterprise visibility into what is our capacity, where are we assigning resources, where do we need resources that we don't. And it really starts to shine a light on the opportunities in a way that you might not have had without a center like this. So there's a little automation and analytics obviously happening now. And I say a little, knowing what's coming in the future. If you ask someone today and looking at this, you're like, there's a ton of technology. Yeah, that's true. But as we're thinking about AI and analytics, again, a theme of what you've heard today, I think, is that we're scratching the surface. So in the design period, we will ask, what can you automate? What is appropriate to automate? And certainly do that where you can. A lot of times that'll be done through the electronic medical record or whatever the operating system that's being used for this placement and throughput process. There are some key elements, though, that are coming that are going to really have a huge impact. So one supporting technology I'll throw out is real-time locating. So again, you heard this from Megan earlier talking about trains. The same can apply in terms of it adds a lot of value to have real-time visibility into where your patients and your staff are. Doing so enables a lot of automation that you can't do without it. So if I'm a trauma surgeon and it is required by the state that you document the in and out time every single time a person enters or leaves a trauma bay during a resuscitation, there's a lot going on, a lot of important things going on, and sometimes writing down the time the surgeon walks in gets missed. So it ends up being documented 20 minutes later. It might be off by a few minutes. Is that really a big deal? If I have a badge that tracks my location throughout the whole entire hospital, it knows when I walk in the room and documents that immediately. So minor example there of the benefits. On a patient perspective, you can track the patient's journey as they go from pre-op to OR to recovery to inpatient. It eliminates a lot of documentation, which all goes back to the provider burnout and staff retention that I mentioned at the beginning, trying to make things easier for the people that went into this field to take care of patients to take care of patients. So having a technology like that really enables automation and also gives you insights to determine, like, how should we configure our facility in the future? Like, where is stuff? Like, literally, tons of time gets wasted looking for like an X-ray machine, an EKG machine. Where is stuff? Let's find it. Pull it up on the screen rather than chasing someone around the halls. So there's a lot of tangible impacts. I'm very bullish on the RTLS technology in healthcare because it has a ton of opportunities. If you think about the predictive analytics, though, looking into the future. So today, you can get a look at, okay, here's the beds we have, here's how many are open, here's how many are closed. How are we looking? You can get a sense of if you implement a change to your nurse staffing ratios, you'll know this center is going to rapidly see if it's helpful or not helpful. So it's great, again, to have that enterprise visibility. Looking into the future, though, we're going from what do things look like and what do we think might happen into better preparedness by predicting. So if you've got a staffing shortage, which just about every single hospital does, of nurses, we're going from a place today of where you can look at, here's tomorrow, this is what we think we're going to need. We're going to be 13 beds short. We need an additional nurse in this unit, to predictive analytics and integrating that with your staffing. So rather than having someone manually managing Excels, which, as Ben said, still rules the world, can't lie about that, but you move into a much more sophisticated staffing model, which is less disruptive for the nurse, gets them where they need to be for the patients, and it's a win-win for everyone. Other models that the Command Center allows you to do is you can move into determining the right level of care. So right now you've got a person looking at, okay, this patient's in the emergency department, they came in with this reason, where do they need to go? And it requires a lot of manual intervention and review to ensure they get to the right thing. You can automate that. You can predict, from a revenue perspective, you can predict your likelihood of getting paid for this. Not because that affects care, it does not, but from understanding making sure that what you do aligns with insurance so that they do pay you for the care you're providing. I know that's the less fun thing to talk about, but that's the reality, is they have to consider this because the rules of the road on that front are so complex right now. So there's, again, I could go on and on all day about this, but I won't because lunch is coming. But those are some of the things that really are to get excited about on this front, I would say. This is the last slide. I took this, Daniel Barchi made this. He's a CIO of a very large health system, CommonSpirit, and actually was the CIO in Roanoke and Carillion at one point, earlier in his career. But he presents this Maslow's hierarchy of needs, in its technology version. So, you talk about AI and analytics, and it's so exciting, and you know the promise is out there. There's tools that I didn't even mention in this presentation that are going to have real, huge impact and huge promise. Like, I don't know if you've heard of like digital scribes, for example, where you can have a mic in a room with the patient and doctor, and it transcribes the note for physicians, so they don't have to spend what we call pajama time at the end of their shift when they should be at home or sleeping, documenting their notes and making sure they've got everything they need in there. Now, that's something that's booming in the market right now because once it's out there, people are screaming for it because there's such a need. On the flip side, another thing that contributes to that pajama time is patient messages. Like, obviously, it's great that we have the ability to log into a portal and message our doctors and get answers. It takes time for someone to answer those. And you can use agents in now to respond to them, or at least get them into a draft form where someone can look at it and be like, yep, that's good, send. So again, just automating and using that AI to lessen the burden and make it easier for folks to deliver that care. On the revenue, a couple other AI use cases. The revenue cycle, you can automate so many archaic functions, frankly, exist in the revenue cycle stream of health there. The framework that gets used in claims for submission is 30 years old. It's as old as me. So there's a lot of low value, low hanging fruit that robotic process automation, AI, you can become more and more mature, but there's just a boatload of opportunity in that space. I talked about bias earlier and how, whether it be system or personal, unintentional or not, that plays a role in care, unfortunately. And you can leverage AI at times like triage, for example, when you go to the emergency department and you have a model that's not doing the triage, but it's in the background, and it's going to run what the human puts into the computer against what it expects to be in the computer based on your chart. And if there's a discrepancy, it's going to pop up and say, hey, you said there were 3. I think they're a little more severe. There are 4. Or do you want to maybe take a look at this? Or you could disagree. That's fine. But that's something that's going to track over time. And so we're human. We are, whether you're in healthcare, any industry, we have our own, life experience that shapes us. And these tools can help make sure, not make sure, but correct for that inequity as best we can. So if we're developing things in an unbiased fashion and leveraging in scenarios like that, we can help close that gap that exists based on your outcomes by zip code or your gender or your race. So it's really important stuff, really exciting. And just to wrap up on this diagram here, it just kind of sets the stage for AI is so exciting and there's so many opportunities. I just touched on 4 of what is abounding, but we do have to recognize in order to holistically address this and truly make an impact, you have to account for all of the hierarchy of needs. You've got to get your security in line. You've got to have a strong infrastructure. You've got to have your applications in place. You've got to have your people in place too on the governance front. And if you get those things right, then you really enable the exciting things that are to come. So I appreciate the time this morning. It's been great. And I'm going to turn it back over to Jay now, I believe. I think I've ran out of time.
Yeah.